Good morning, everyone. Thanks, Dr. Atul, for inviting me again for this course. And as always, the hall is full. That is the identity of Atul sir's course. So I'll be talking about the submacular hemorrhage, and I'm sure that many of us have seen situations like this, which really brings some stress lines to us that what next. So before we actually move forward, I would say that it's always good to think about the etiology before you plan the management. These cases could be because of the trauma, CNVM, PCV, especially in this part of the world, ruptured RAM, or sometimes because of the coagulopathies or Valsalva. Why do we really need to treat these cases early? Because it leads to the irreversible damage to the photoreceptors because of the various mechanisms as mentioned here. And the options available range from the intravitreal gas, intravitreal TPA, or a subretinal TPA along with pars plana vitrectomy, or sometimes the best left alone. Before I really move on with the cases, I would just put a word about the TPA. This is primarily a serine protease which converts the plasminogen to plasmine, which liquefies the submacular blood. Let me start with the case of a 33-year-old female who came to me with a sudden vision loss in her left eye since 12 hours and following ocular trauma. There was no systemic history, nothing relevant, and I was lucky to see her within 12 hours of the injury. Her left eye visual acuity had dropped to counting finger 1 meter. The right eye was pretty much within normal limits. And these were the fundus photographs of her left eye. As you can see here, there's a large submacular hemorrhage covering the macula. And this was the OCT, which actually clearly shows us that this hemorrhage is pretty much subretinal because I can see the RP here. And this is primarily a subretinal hemorrhage, not a sub-RP hemorrhage. So we had a lot of discussion with her. She was really well to do, and we discussed about the TPA and the cost associated with it. But she went ahead with the option of intravitreal TPA along with the gas injection, and we decided to give her the prone position for 48 hours. And this was the picture on day 8, where you can see that the hemorrhage has actually pushed aside with the visual acuity improvement from CF 1 meter to 2000, and now you can clearly see the choroidal rupture at the center, and the OCT does show some small amount of a subretinal hemorrhage with the choroidal rupture very close to the fovea. We decided to observe, and you can see that that thin hemorrhage which was there, which has cleared over the time, and the visual acuity has improved to 20/40, and the choroidal rupture also seems to be healing close to the fovea. The question was TPA required? Just because she could afford it, that's why we could give her the injection of 26,000 rupees. But I was fortunate enough to see a case who was an 18 years old boy, which I saw just like 3-4 days after I saw her first follow-up of the previous case. This boy had a vision loss in the right eye since last 2 days after the cricket ball injury, and this was a picture which was almost identical like the previous case, where you can see the subretinal hemorrhage, which is again seen very clearly on the OCT. You can see that the RP is still intact. There is no sub-RP hemorrhage, and the visual acuity is CF 1 meter, and we decided to go ahead with the gas only with the prone position. And this was a picture after a week where we can see that the hemorrhage is pushed aside, the choroidal rupture is seen, and a 21/26 vision improvement, which was very, very good, and a very thin hemorrhage as it was seen in last case. And we learned that we really do not need to do anything for this hemorrhage. We decided to observe this patient, and you can see that he is almost recovering towards the normal fovea with the visual acuity improvement to 20/60. However, some outer retinal damage is seen at the subfoveal region along with the choroidal rupture on the nasal part. This is another interesting case of a 71-year-old male who presented to me with a vision loss of last 4 days. This was a very recent case. The right eye did show some RP changes, but with the visual acuity of 20/30. But if you look at the left eye, the visual acuity is 20/100, and primarily a subretinal hemorrhage, which it does show some yellowish kind of a lesion there, which was primarily kind of a PCV, where you can see that the subretinal hemorrhage is there with the subfoveal involvement as well. So the question was that, do I really go ahead with the pneumatic, or can we just treat with the primary disease? We had this discussion, and he was very reluctant to maintain the prone position. I said, okay, let's try just Eylea injection. These were the ICG pictures which which is suggestive of a polyp, and you can see that the fluorescein is not helping much. So we decided to go ahead with the Eylea injection, and we saw him after a month where the visual acuity had improved to 20/30, and you can see that the hemorrhage is pretty much becoming yellow. So I was really feeling bad that I should have done a pneumatic retinopexy, and you can see that this hemorrhage is actually almost at the subfoveal area, which is pretty much sitting there. Polyp is still there, and we decided to give him another shot of injection, and he comes back 1 month later, and this hemorrhage has actually cleared. And you can see that the polyp changes are still there, but there is no blood subfoveally. The visual acuity has improved to 20/30, and this patient was under follow-up, and this is the picture after 3 months after the second Eylea injection. The polyp is also regressing, and you can compare with the baseline picture. There is a significant improvement. I like to repeat the ICG whenever I decided to observe the patient, and you can see that the ICG also shows a regression of the polyp, which was a very, very positive sign comparing with the baseline picture. Let's move on with the case 4, which is a 43-year-old female who presented with a sudden painless vision loss in last 1 month without any history of ocular trauma, and the left eye had a visual acuity of hand motions. There was a vitreous hemorrhage. These are the screenshot of the surgery where we can see that the vitreous hemorrhage is there, along with a large subretinal hemorrhage and a pretty much yellowish change which has occurred, which seen in the other quadrants as well. And these are the OCT pictures which I did through the vitreous hemorrhage. That's why the picture quality is not great, but you can still appreciate a sub-RP hemorrhage here along with the sub-retinal hemorrhage. We had a detailed discussion with this patient, and we decided to go ahead with a pars plana vitrectomy by taking a chance, as her visual acuity was anyway hand motions. So these are the surgical video where you can see that the hemorrhage is pretty getting old. This was almost a month old hemorrhage. That is why these changes are there of this discoloration, and you can see. And then I'll be using a 38 gauge needle, and this is the first prick I did outside the arcade, and this was failed. Then I actually went ahead and tried at the edges of the subretinal hemorrhage. This is usually a best space to go inside because the retina is slightly elevated. You will be able to make a large bulla. As you can see that now I'm filling up the subretinal space, and my goal is actually to make sure that this bulla reaches to the disc, and I cross the fovea, and you can see that already there is some change in the color, and I was very happy. And then I just went ahead and left the bulla like this with the fluid air exchange, and then I injected C3F8 along with Avastin. So this was the 1 week picture where we can already see a lot of improvement of 20/100, and you can see that the hemorrhage is pushed aside. But if you look at the OCT, the subretinal hemorrhage is still there a little bit, but the sub-RP hemorrhage was pretty much the same as it was before. So we followed up this patient. She improved to 20/50, and then we planned a cataract surgery over a year time, and she is right now doing very well with 20/40 vision, but this sub-RP hemorrhage was still bothering me. I'll come back to this later. Before we actually move forward, let's talk about the approach to the patient. These are a couple of the things which you have to count upon, like duration of the subretinal hemorrhage, which the color of the hemorrhage can give you some clue. However, the importance is the cause of the subretinal hemorrhage, various surgical approaches, dose of intravitreal and subretinal TPA, and the level of hemorrhage. This is usually what I follow. If the patient is less than presenting within 2 weeks, then I would go ahead and do a gas injection. If it is more than 2 weeks, then intravitreal TPA is like plus minus, but gas is definitely important. But if it is more than 1 month, then I will definitely take this patient for subretinal TPA. As we already discussed about the cases, I think the more important is the various surgical approaches. You can actually perform a 180 degrees retinectomy and the clot removal. However, the visual acuity improvement is still questionable. What about the dose of the TPA? The intravitreal TPA is usually recommended around 25 microgram per 0.1 ml, and the subretinal TPA is up to 100 microgram you can inject comfortably. Let's talk about the level of the hemorrhage, which is the area of interest for me, where you can see that the subretinal hemorrhage we could clear very comfortably with the gas only, but what about this sub-RP hemorrhage? Subsequently, I had another patient with a sub-RP hemorrhage where you can see the subretinal hemorrhage is still there, but the sub-RP hemorrhage is quite huge. I went ahead and did a gas injection because he was presenting a week after the hemorrhage, and you can see that the subretinal hemorrhage, I'll just take 30 seconds more. Subretinal hemorrhage is cleared, but the sub-RP hemorrhage is still maintaining. His visual acuity has improved to 2200, but I really wanted to do something about this sub-RP hemorrhage, and I decided to do a subretinal TPA with the gas injection, and the results were very surprising to me because the conventional training is that you really do not bother about the sub-RP hemorrhage, but in this case, you can see that the sub-RP hemorrhage has cleared, and the visual acuity has improved to 2125. I would leave you with some of the unanswered questions that we are still not sure about the role of intravitreal TPA. We are not sure about the toxic threshold of these injections, and the sub-RP hemorrhage needs further clarification. So the take clinic message is that the early treatment is the key to get the better visual outcome in these cases. Treatment needs to be tailored according to the etiology, extent, and the duration. However, the combination treatment is something which works at least better in my hands. However, the close monitoring and the treatment of underlying cause is important for maintenance of the vision. Thank you very much for your attention.